Good afternoon and a warm welcome to the great new venue that we are seeing for the first time. And it's really amazing that we have now such good venues coming up within our country and good environment and place to have good conference and academic sessions. I thank you all to be here in this hall. And we'll be looking at decoding and conquering hard cataracts with phacoemulsification. Now, as part of being in India, we do get an undue share of cases coming with hard cataracts. We all know that there are a lot of reasons for this. One is fear of surgery, so they keep on postponing the surgery as long as their patients feel that they can somehow manage their day-to-day activities with restrictions which they slowly get adjusted to. It's also, we get these cases with hard cataract also because there is one section of the population which don't have a easy access to a healthcare system. Therefore, they will come late to us. Of course, as part of our training, as part of our practice, we have to be geared to handle all kind of cases that are coming to it. Now, the hard cataracts are a special separate category because besides surgical skill, these cases call for a strategy. You have to define a strategy from case to case how you are going to handle. And we don't have any scale where we can judge the hardness on slit lamp or preoperative examination. The real challenge you face once your phaco probe touches the lens, that is how your first sweep tells you, oh my God, okay, this is what I'm going to handle it. And your strategy should be such which can change and adapt to as it progresses. So you have to balance it out between using the right kind of a power, using the right kind of a strategy, dealing with the lens also, dealing with the hard nucleus, and also be gentle onto the endothelium. So in today's, we have presentation. We'll be starting with Professor Jagatram. He'll be speaking on how to crack the hardest ones, pearls of wisdom, followed by Dr. Sartaj Garewal on mastering the MyLoop nuclear fragmentation, and then I'll be talking about flax. For some reasons, Pradeep couldn't come for the session today. So I'll start the session, and I'll request Padam Shri Professor Jagatram to share his experiences on how to crack the hardest ones. I think he has a great experience of dealing with these kind of cases. Thank you.
Thank you very much, Dr. S.P.S. Grewal, for giving me this opportunity. As you rightly said that majority of the patient in our country, they delay cataract surgery because they are finding better to read for near, they become more myopic, and these hard cataract particularly, many of them, they induced myopia also. But when it comes to surgeon, they find much more problem to deal with them. I will be speaking on how to crack the hardest one, pearls of wisdom. What are the challenges in performing phaco surgery on black or brunescent cataract? Since there may be poor red reflex, capsulorhexis is much more difficult to perform. High phaco energy. Actually, these hard cataract may need high phaco energy, and corneal endothelial damage more likely to occur in these patients. Leathery hard nucleus, they resist fragmentation during chopping. Chopping is much more difficult, whether it is a direct chop or whether it is a stop and chop. It is much more difficult to perform in these cases. And then emulsification, more energy is required. There are much more higher chances of posterior capsular tear compared to other cases of cataract. More zonular stress and much more risk of subluxation. There are increased chances of iris chafing. Some of the pre-operative consideration, we have to see each of the patient very carefully, and we have to dilate the pupil of each of the patient to see how much dilatation of the pupil is achieved, whether it is adequate dilatation or whether we will need iris hooks or ring to adequately dilate the pupil. We have to also see for endothelial cell count. If clinical examination showed that endothelium, there is corneal guttata, in that situation, surely I think you should go for corneal endothelial cell count. Then we decide whether we can do phacoemulsification or whether small incision cataract surgery is good for this patient, or sometime one should not even hesitate to do extracapsular cataract surgery. I think you should not have ego that I want to do phaco only. And then whether bag is stable or what is required, whether phaco or small incision cataract surgery. Of course, many of these patients, they need ultrasound B scan if it is much more hard and fundus view is not visible. And then we have to have with us a single piece. Most of the time we keep, but sometime or many times multiple piece, 3-piece IOL. Sound. This is a very hard cataract. This is white in color, but we were knowing that this is a brunescent cataract. And here, anterior capsule is stained with trypan blue dye. Hydrodissection done. And ultimately stop and chop, and then separation of the nucleus, and then multiple fragmentation, and particularly one has to be very careful each time when we take out the last piece of the nucleus. We have to reduce the power and the energy and parameters. So here capsular bag is filled with viscoelastic. Viscoelastic removed from the bag, and then rock hard cataract or brown cataract, very poor glow. Stain the capsule with trypan blue dye. We might use sharp blade chopper. Viscoelastic is repeatedly put into anterior chamber to coat the endothelium. And parameter is set. For particularly hard cataract, once we know it is very hard cataract, it may need more than 50% power. Here in this case it is 70%, or it may vary with the density of the cataract. So all the parameters, they may vary. Most of the time we try that whether we can do direct chop, but many times we fail. Then we try to do stop and chop, but here we succeeded in chopping fragmenting it into 2 halves. Then stop and chop. Stop and chop is done most of the time, because when we do stop and chop, we make a groove, and little wider groove, and this gives a space. While you fracture the nucleus, it gives a lot of space. And once once you take out even a single piece of the nucleus, then I think it is not difficult to remove the cortical material. Then comes a very, very leathery cataract or very, very hard cataract. This is a jet black cataract. Attempt was done to do direct chop. It may be difficult, but then one may not struggle, then one may do stop and chop. And viscoelastic is put, repeated viscoelastic, because we don't want to damage corneal endothelium. Despite putting very, very high power, 70% or even 75 to 80%, it may be difficult to emulsify. And then, of course, while it is the last piece, we should take precaution. We have to be a bit slow, and in all these patients, I think patience is the key to success. Then comes a patient with the hard nucleus and small pupil. It is a double challenge, and you have to be prepared in such patient, in all the cases, that you should be ready with the Malthusian ring or iris hooks. But here we thought that we will try that whether pupil comes down or not. Already it is a small. And rhexis, it should be larger rhexis in these cases compared to the other cases. So here it is done behind the iris without much visualization, but with experience. But it was found that it was very, very hard cataract, and even increased power was not doing much to do even the trenching in this case. So it has, pupil has come down, pupil has become small. Viscoelastic injected, and then I planned that okay, I will apply iris hooks. Actually, this trench, because direct chop was not possible here, and this trench was made, and this will give adequate space when it is fractured into two parts. And you have to have patience, and you have to be slow also, because it is better to make multiple pieces of each of the nucleus. While you take out one small piece of the nucleus, it gives a good space for the nucleus to move. And then each of the piece, if you make 4, you have to make then 8. Each of the small piece you have to divide into 2, and further smaller piece. So here I think a lot of patience is required to deal with such patients. And viscoelastic is good. and then cortex is removed from the capsular bag. And then implantation of IOL into capsular bag. Once I think capsular bag is intact, you can use any type of IOL. Most of the time recently we use a single piece IOL, but most of the time we keep 3-piece IOL for such patient because and then comes this is one of the patient with rocky hard cataract with corneal astigmatism, and patient was also not cooperative even for marking. This patient has 3.39 diopter of astigmatism. This SN6AT9, this IOL, this is Alcon IOL, this was selected, and then what challenges were expected? Damage to corneal endothelium, runaway rhexis. These are the common thing which happens in these cases, or even then rhexis become difficult in these cases, but here it was done, a larger rhexis was done in this case. I think rotation is very, very important. Once you do hydrodissection, rotation is very, very important because you become much more confident. And if you do direct chop or stop and chop, I think this gives a much more confidence to surgeon that okay, I am succeeding. And of course, you have to put viscoelastic in between and fracture each of the nucleus piece into many of them because if it is a half nucleus or so, it will touch the endothelium, more damage occur in such patients. So it is better that most of the time, or mostly one must do phacoemulsification in the capsular bag. And here I am trying to make multiple pieces. And this is jet black nucleus, and you can see that there is a lot of good relief while you see the red glow. A lot of patience is required to remove these nuclear pieces. And finally, the last piece of the nucleus is ready to be removed, and here it is absolutely jet black nucleus. And then last piece. And sometimes these cases you may, even small piece may hide somewhere behind the iris or in the angle. And on the first day it may come into anterior chamber. That may be usual story in these cases. And here we are implanting single piece toric IOL. Callisto is used, although marking was also done before because then you have to remove the viscoelastic from front and behind the nucleus. And then come many of the complications which may occur in these cases. It looks good. It looks that there is a very good red glow. But this is again brunescent cataract. no rupture of the posterior capsule. You can see here what is happening. I had the feeling that something wrong is there. And here nucleus has gone. So you may do 99% good, successful this, but you have to be ready for this. Here, you remove, you don't hunt the nucleus. Best is just let it go. Remove the cortex. Do anterior vitrectomy and implant IOL in the sulcus. And because why I place suture? Because retinal surgeon is going to remove the nucleus afterward. These iris hooks were placed by the retinal surgeon and removed the nucleus in the same sitting. Then sometime you may need IOL scaffold. This is again very hard cataract. Lot of viscoelastic repeatedly placed into anterior chamber. And here I realize that there may be PCR. Then I planned that I will not remove this nucleus piece. I will first implant IOL into sulcus and then remove the nuclear piece, whatever residual nuclear piece is there. So IOL was placed in the sulcus and this nucleus was removed. One of the heptip is still outside in the, but it is placed into sulcus, and so this scaffold technique help to prevent further dropping of the nucleus and further complication. You may get some of the other complications, such as here. This is iris shaping here in a black cataract, and then this is after completion of the case. There may be lot of edema along the side port. Despite or taking all the precaution, you may have Descemet's membrane detachment here. This is a small Descemet's membrane detachment. So newer technology such as Phacoemulsification laser, which Dr. SPS Grewal will be explaining in detail. Surely I think it helps, particularly in these black cataract. There may be Jepto or manual CCC, or whether you use submarine chopper or other thing, or this Dr. Sartaj will be discussing the my loop and beyond. This I will not speak much about it, but maybe small part of the video, such as definitely I think this make the job much easier. Capsulotomy and nucleotomy here done with Phacoemulsification. It become already it is a chopped one, but then it chopping become easier, and phaco power and energy required will be much less, and it take less time also. So one should not think that technology is a failure. Technology definitely help in case-to-case basis. This is 1.5 diopter IOL. This is a case of eye myopia. And this IOL is not available in single piece. 1.5 diopter. They are available in some of this Alcon and J&J sensor AR40. So then take home message. Pre-operative assessment is extremely important. We have to note what is the density of the cataract. We have what dilatation of the pupil is achieved, zonular status, endothelial cell count, particularly where there is a cornea guttata, or otherwise also it may damage in these cases. Staining of the anterior capsule using trypan blue dye in jet blue cataract, jet black cataract, larger CCC, and we have to ensure rotation of the nucleus. Keep using viscoelastic substance, dispersive viscoelastic to protect the endothelium. Always have a backup plan, CTR, pupillary expanding devices, even 3-piece IOL. And lastly, do not lose patience. I think patience is the key to success. But you should not have ego if you have to convert it into extracapsular cataract surgery. I think that ego should not be there with you, because patient want vision. If it is a dropped nucleus or if there is a white cornea, I think it is better to do ECG. Thank you very much.
Thank you, Professor Jagtram, for captivating and mesmerizing videos. Now it's open to questions as well as comments, and anyone who would like to share their experiences in handling these cases. Can you please keep the mics ready for the audience? Anyone who would like to make a comment, ask a question, or add anything to it? So, out of the videos that sir has shown, one
we make a call whether to go for SICS or Phaco, like depending upon the skill that I understand, but also like where do we make a line, like how do we fill a boundary that this case should be better to perform an SICS or Phacoemulsification, like is there any ocular comorbidity coexisting, that's the only defining criteria, or there is some specific set rules, or is it individualized and like?
I think this you have to assess from case to case. If it is a black cataract, and such as I was confident, okay, I started with Phaco. But if you thought that, lot of Phaco power is used, nothing is happening, you cannot chop it, you cannot do Phaco much more, you can convert it into extracapsular cataract surgery. You can extend it both way. Or initially, if you are not confident that, okay, I will fail, then from the very beginning, that will be much better. If it is from the very beginning, that is the best. You decide that whether you want to do Phaco or you want to do small incision cataract surgery, because that will be the best. In these patients, we explain in the consent that your cataract is very, very hard, your recovery will be delayed. Don't give a rosy picture that no, you will be 6/6 first day. You have to tell that your corneal swelling will occur. You give even hypersol to these patients. But if it is better to decide before surgery if endothelial cell count is low. It is better that small incision cataract surgery or extracapsular will be better, because there you are taking out the nucleus. Little loss will happen, but in Phaco much more loss will happen. So I think you have to decide. If your experience is so much thousands or even several thousand of patients, then you have to decide whatever your heart say that you have to do this.
Yeah, I think it'll be whatever works better in your hands. If you're more comfortable with Phaco, you'll find ways to manage. There are tools available for that. But if you're more comfortable with SICS would be a better job. It's less stressful.
You mentioned, you were about to mention something about patients' expectations. I think patients' expectations should not influence the decision of the surgeon. What matters here will be your past experience with similar cases and your results in similar cases, which will decide what procedure you take. And out of the ocular parameters, the endothelial cell count. If you already know, as sir mentioned, that endothelial cell count is low, right from the beginning, plan for X-ray. No, at the last, yes, please.
Sir, what was the benefit of keeping the cortical matter and placing the IOL in?
No, that was a case where we suspected that there was a large nuclear piece superiorly entrapped in the ruptured, it was entrapped. So, because while doing removing and doing phaco of that piece, it may go down. So, it is better that you implant IOL and bring this piece over to the IOL scaffold. And then easily you are 100% sure that it will now not go down because you have implanted IOL in the sulcus and removed the nucleus from over. Otherwise, it may go down. Definitely there was a tear, posterior capsular tear. Posterior capsular?
Posterior polar cataract.
Yeah, posterior polar cataract.
Yeah.
I think excellent. In these cases, if it is a brown cataract, you may not even know that it is a posterior polar cataract. But each case has to be dilated and has to be seen. And you may not do hydro dissection completely, you do limited hydro dissection. And you must be ready with the hooks or other modalities, even 3-piece IOL. So you have to be much more careful in such patients, such as one of the patient, there was a drop. It was not, we never suspected that it is a posterior polar cataract. So in brown or brunescent cataract or black cataract, there can be possibility, although rare.
Generally, PPCs are developmental, so they present early, so mostly the sclerosis is less, so we get it diagnosed. But until and unless one eye is operated, the other eye may come with NS2 to 3, then we have to.
Yeah.
Thank you. Yeah, I just wanted to make a comment about the small pupil hard cataract case with the iris hooks. So I've never, regretted putting in iris hooks in those cases early, right at the beginning, just because, not that you can do the case without the hooks, but if the pupil comes down, then putting in the iris hooks, it's much more likely that you could catch the capsule edge.
Yeah, even if initially you have preoperatively, we write that what is the maximum dilatation of pupil, it may be fine. Pseudo exfoliation patient, initially it may be fine, but later on during surgery it may go down. But we are ready with the iris hooks or Malaysian ring or any Bhattacharya ring, any of these modalities. So one has to be prepared, mentally prepared in advance, mostly. But sometime if we are not prepared, then at the time of surgery we have to take a call that this is the issue, how it has to be managed.
Is there any role of P-chopping in hard cataract?
Yeah, chopping definitely. Best is many of the patients we succeed in direct chop. But in many of the cases, we make a groove and make a good space and fracture the nucleus and then multiple, that is stop and chop, do chopping of the fragments.
Was the question about pre-chop?
Yes, sir.
The nucleus is so hard, it will be very difficult to put anything into it that's where the my loop role comes, which will come at the end of the session. Pre-chop in a very hard nucleus is very difficult to do.
So what what are few tips to do a better direct chop in such cases, like for a better hold in?
I think if it is a moderate type of moderate density of cataract, you can do direct chop most of the time. If it is a black cataract, jet black cataract, you may not succeed many times.
But mostly you would need a sharper chopper. You would need reasonably high vacuum parameters to get a nice hold. Make sure you go far enough with the chopper under the capsule, and be prepared to sort of chop it at multiple levels. Don't let go too early. Don't like NS2, NS3, they're brittle. They'll crack quite easily. Here you really have to keep holding on to it and pull it apart.
All the depth
So-
of it.
It's also
Okay, thank you.
it's also important to understand the physics of the forces acting between the tip of the chopper and the tip of your phaco probe. Your movement should be such that there are not much tangential, otherwise it will start rotating like this. So a good hold, that means when you go first time, you should go deep enough to have a good hold, and then your chopper should be such that it only comes in this direction. Movement like this and like this is to be avoided. So it's basically interplay of forces and keeping them in a direction so that you don't lose the hold. As long as you have a hold, you will be able to chop.
Sir, I have a question, please. Excellent videos. Just one question. Lot of these brown cataracts occupy the full bag. So when we're doing this direct chop, and there is a lot of stress on zonules, especially for people who are learning phaco. So would you recommend to do direct chop, or would you ask them to do a good debulking prior to proceeding with the chop?
You are right. I think you are much more right, and the answer of your question is the second part. Initially, for the beginner, it is better to do debulking. It is better to do stop and chop. What is stop and chop? We make a groove. In these cases, we make larger groove and separate fracture. And then making it 4 pieces, 8 pieces are much more easier. But doing direct chop for the beginner is much more difficult. This is my opinion. It may differ, but mostly I think stop and chop for the beginner is better than direct chop, particularly for hard cataract.
Okay, thank you.
I think that's a very good comment, and even if I am doing flax and it's a hard cataract, I would still like to debulk for the same reason that you have said, that you have space to work around. And in these cases, two things which are very important, as has been mentioned, is the first divide and the first chop. If you have divided the nucleus into two, irrespective of how hard it is, you have won 50% of the battle. And if you have able to remove the first fragment, that means now all you need is, as he said, patience and perseverance, and you will be able to complete the surgery. Any other comments before I sum up the...
There are some mentions of ultrasonic pre-chopper in hard cataracts. Do you have any experience about it, or anybody in the audience has any experience about it? Ultrasonic pre-chopper or ultra chopper?
We don't have experience of ultrasound chopper or ultrasonic chopper, but I think it may be good for not very extremely dense cataract, but since I am not sure because I have not done.
It's relatively new. It looks very interesting, and kudos to innovation. It's always amazing. My fear is I use the MyLoop a lot, and I just feel the MyLoop seems safer and easier because there'll be some logistics also with the ultrasound chopper, that then you remove it, you switch back to your ultrasound probe, or you keep two machines. But it is excellent. There's no doubt. And the videos that I've seen, it'll cut through anything. But that's also a fear, that you don't want it cutting through anything you don't want it cutting through. So yeah, but it'll do the trick. Why not?
Sir, I have a small question. Considering hard cataracts black, say you said black cataract, sir. So what may be the post-operative outcome between SICS and doing phaco?
I think if you can safely do phacoemulsification, it is fine. But otherwise, if it is absolutely jet black cataract, if cornea become white,
No,
nucleus
sir,
is
that is not the
dislocated.
question, sir.
So
Question is what is
outcome may be better in small incision cataract surgery or even ECC, if we expect that much more complication or much more endothelial damage will take place. I think outcome may be better in the initial planning of extracapsular or even small incision cataract surgery.
So in black cataracts, it should be indicated that you should do an SICS rather than phaco if the complications are
No,
lower.
it is a experience of the person. We have done phacoemulsification, we have done small incision cataract surgery also. We also convert to such modalities.
Question is very specific, sir. Post-operative outcome.
Okay, can
In
I?
the right hands,
I'll
it will be the
answer
same outcome.
Okay, I'll answer it differently. One, in a hard nucleus is so big, 6 is not going to be easy. Now you have a choice. You have a choice to have a clear cornea on day 1 in ECCE and astigmatism changing and refraction changing over the next 2 months versus a hazy cornea and poor vision for a week, but better results in the long term. So this is where you will weigh between your experience and your competency to decide what you're going to do.
Okay, thank you.
So there was mentioned that red glow can be erroneous sometimes. That was a nice video. It is only when you touch the nucleus that you find there is some issue. The change in plan has been beautifully demonstrated in the videos. One point he mentioned, I would like to re-emphasize, is about the hidden pieces. In these cases, small piece sometimes goes, and with the fluidics, it goes so fast under the iris and between the iris and the capsule, you can't find it. So what I follow the strategy in these cases, that when I have a fragment, I'll remove it completely, then go on to the next fragment. There is always a temptation, I have removed most of it, let me go on to the second fragment. So in these hard cases, first fragment, whatever its remnants are, clear completely and then go on to the next one. It's also important to understand what is happening at the tip between the aspiration and between the flow. Many times we'll be trying to get these pieces to the tip with the help of imagining that it is the aspiration which is going to pull it. No, it is you need to be always clear about in your mind that what are the fluidic movement taking place in the anterior chamber, and you should use the irrigation flow to redirect the fragments onto the tip of the phaco tip so that it's engaged easily. Handling of the complications has been shown beautifully, and last is that be friends with the retina surgeon.
I think important is that you don't hunt the nucleus. In a case where there was a drop of the nucleus, without knowing much fault of, I did that case, but it went down. So I left it, placed the IOL in the sulcus, and my retinal surgeon, I think Dr. Anjani is here. She did excellent job, I think same day. Your retinal surgeon should be ready to do the job, and you have to tell the patient. You should be very confident and telling the patient that your nucleus has dropped. I told patient that, but patient was very confident. Doctor Saab, whatever you do, and patient had excellent outcome.
So now we move on to the next talk, which is very interesting, mastering the MyLoop nuclear fragmentation devices. Dr. Sartaj Grewal.
Hi, good evening, everyone. Really appreciate you all taking out time to be here for this. So just continuing with Professor Jagatram sir's talk, I will be discussing the MyLoop, which is a device that has now been around for some time. It's marketed by Zeiss in India. Not all of us will have skillful hands like Professor Jagatram, where you can do direct chop or even stop and chop. Some of us, for whatever reason, might not be very comfortable with SICS. So that is where tools such as the MyLoop really come in. I am a consultant for Carl Zeiss. So, dense, brunescent, maybe black cataracts like these, we come across them in our clinical practice, especially in India, as we discussed earlier. These can pose a challenge for even the most experienced phacosurgeons, can give us a sleepless night the night before the surgery. And these can be challenging, as Sir discussed. The entire nuclear disassembly process is a challenge. Not is it just that, chopping them at first, but every piece, getting it out when they're leathery is just a constant struggle. So what if we could just divide them with almost no force whatsoever. And that is where the my loop comes in. So this is a nuclear fragmentation device that is made with a nitinol filament. When we were discussing technology, this is one that is excellent for hard cataracts, certain other complicated situations. You can combine it with other technologies that are available, such as flax, and with absolutely no energy at all, it can divide into 2 or 4 pieces any density of cataract that you have. So it's a micro-thin filament that's retractable, super elastic. It is self-expanding. The filament itself has a diameter of 300 microns. Fully expanded, it has a horizontal diameter of 10.5 millimeters and an anterior-posterior length of 5.5 millimeters. So this is enough to engulf even the largest of the nuclei that we'll come across. And when it's fully retracted, it has the loop itself has a diameter of only 1.5 millimeters, so it can easily go through a 2.2 millimeter incision. So I'll just briefly discuss how do you use this device. It seems very traumatic in the videos, but it really is not. It's a very safe device and very easy to use. The first step is inserting the my loop, and this can seem a little trickier than it is. What you have to do is you have to center the loop on the incision, engage the incision with the loop itself rather than the shaft of the device, push down, and then sort of take it towards the side and then enter with the shaft. Once you're inside the eye, you just have to make sure that the point from where the loop opens, this should be centered on the capsular axis itself. You want to gently rotate the device so that as the filament is opening, it gently scrapes against the nucleus, maybe even just going underneath a little bit of the cortical matter. This increases your chances of making sure this goes underneath the capsule rather than over it and hitting the zonules. Once it's opened up, you can see the filaments. They should be relatively straight. This tells you that you have opened them up adequately, because if you don't open it adequately, you'll end up putting more force on the nucleus itself and the zonules. In most cataracts, even if they're dense, you're able to see a shiny reflex at the back. It's a good idea to just sweep the filament across the posterior surface. This helps in dissection and also just polishes the capsule a little bit. Make sure that before you retract the filament, make sure that you're right about in the center. This will increase your chances of getting 2 equal pieces. A second instrument is very helpful in stabilizing the nucleus, because when you retract the filament, it does tend to pull up the nucleus a little bit, which can damage the endothelium. Once you have made 2 equal halves, you can easily rotate it and then go ahead and divide it into 4 pieces. Once it is divided, it is important to just use the second instrument. Make sure that you get the filament out. Some of the very leathery cataracts, it can be a little sticky. And when you're removing the device, the edge of the loop can be like a hook, so make sure you rotate it adequately so that it doesn't engage the capsule or the iris as you're pulling it out. So I'll just discuss a few different situations where you can use the my loop, and it really helps. So this was an 86-year-old female with a dense cataract, poorly dilating pupil, and some phacodenesis. So we went ahead, we did the capsulorhexis, and I used the my loop after that. And you can make out that the nucleus was reasonably mobile, but the fact that, as Dr. Gurwal mentioned earlier, forces. The force that the my loop is applying is purely centripetal when it is cutting the nucleus. It is not applying any force tangentially or anywhere else. So you can very easily use this in situations where the zonules are not very strong. So I just divided into 2. I didn't want to rotate it because I was a little afraid about the zonules, but when I went in to try to chop, it was actually quite mobile and rotating freely. So I actually decided to come out and go back in again with the my loop and use it to actually then divide into 4 pieces. That's the other good thing with the my loop, that it's not that you can only use it at one particular stage. You can use it any time in the surgery. Even if you have a failed chop, let's say, and you want to switch over to the my loop as a rescue device, you can do that. So then I went ahead with 4 easy pieces. It's quite easy to just go ahead and emulsify these pieces. And as someone was mentioning that, when you're starting off, if direct chop is very tough, this is a very good way of getting smaller pieces, learning how to handle these really dense quadrants, and then you can progress to chopping a whole nucleus intact. I placed a CTR, then went ahead, removed the remaining pieces that were there, It was a fairly successful outcome with the bag in the lens, with the lens in the bag. Just be careful with the cortical material removal. With the CTR, it can be a little tricky at times. This next case was where I had missed the phacodenesis preoperatively, or could have been a little iatrogenic also at the time of chopping. So we can see over here superiorly that this nucleus is actually quite mobile. So I went ahead, I placed a CTR, and I used the MyLoop after placing the CTR because that gave me some support. And it was quite easy to actually get the MyLoop in, get it around the nucleus, divide this into smaller pieces, which then could easily be removed, and eventually, again, IOL single piece in the bag. So it's a really versatile device, not just for hard cataracts, but a few other different situations. Another situation where I actually like to use it is small pupils, especially patients with IFIS, because when you try to do a hydrodissection in these patients, it's very likely that the iris will just come out at that time itself. Even hooks and rings have limited success in patients with IFIS because that pupil is just always ready to come out of the wound. So I find that I can just go ahead with this device, finish a capsulorhexis. If as long as you open it in the right direction, making sure you're going along the cortical matter, you will be inside the bag. You can go around again. Take it a little further up beyond the midpoint so that you polish the capsule, do a little bit of dissection, and it'll divide it into 2 and even 4 pieces if you want. And then even through a small pupil, it's actually quite easy to go ahead and pick up those 4 pieces. In patients with corneal opacities, again, sometimes you don't have enough reflex or view to be able to do a good chop. So in those patients also, again, the MyLoop actually works very well. Even with a dense cataract, you can easily break these up and then go ahead and safely emulsify them. So some of the advantages to summarize is, again, a very versatile device, not just hard cataracts, but even smaller pupils, patients with IFIS. You can use it without hooks. The shiny reflex at the back is what you want to look for, especially in the initial few cases, to make sure that you're in the right plane. The forces that are applied are very safe and gentle on the zonules. And again, it can be used with a CTR, no problem. And no matter how leathery or dense the cataract is, it will go ahead and divide into 2. And trust me, the first time you use it, it is astonishing how little force it takes. And it can definitely reduce your overall surgical time and also the phaco energy that is used. And also, coming back a little bit to the SICS and phaco debate that was initiated, SICS is an excellent procedure, has its place, but as these phaco machines are getting better and better, and we have incredibly stable fluidics, we are actually relying more and more on the fluidics to extract the lens rather than just the ultrasound energy. And in this particular case, this machine was going up to 700 millimeters of mercury of vacuum. And even at 685 with this hard cataract, it's incredibly stable to just emulsify it quite easily. So as machines are getting better and better, phacoemulsification, even in these very hard cataracts, is a safe option for your patients. Thank you.
Thank you so much, Dr. Sataj. It's an amazing technology. It's a great value for money, and there's no heavy investment. But I don't know why it is not popular. How many of you are using MyLoop from the audience? No.
What is the material used for making the loop? How does it differ from the stainless steel wire which is used for the tonsillar snare technique?
So it is a nitinol filament. So it has much better memory than stainless steels. So as a result, when it opens up, it actually opens up in the exact shape of the nucleus rather than just an oval or a round. The posterior part is curved, mimicking the nucleus. It is a little softer, a little more elastic than stainless steel. So it's less traumatic, more malleable as you are sort of deploying it inside the nucleus. Lesser chances of you causing any kind of damage inadvertently.
How much does it cost and is it reusable?
is cost-wise, it's roughly about 13 to 15,000 for a device. One device will give you about 4 uses, 4 cuts. So after that, it locks out, then you cannot use it anymore. And I feel initially when this device was launched earlier by Ian Tech, and then even when Zeiss acquired it, it had no limit on how many times you could use it. And I have used some of those devices, so those we would ETO. The thing is, the filament over time does tend to fray and break or even bend out of shape. So I can understand why it has a limited use. But even more than 4, I'm sure you could use it, but unfortunately the device locks out. Some surgeons will prefer to maybe use 2 in one patient and then 2 more cuts in another patient. But from the company itself, it is a single-use device.
Excuse me, initial cases, what are the difficulties you faced?
Making sure you insert it, smoothly, because we tend to put instruments based on the shaft itself, but here you have to first use the loop, guide that in, then go in. The second thing is just making sure that you're in the correct plane. For that, I found rather than trying to open it, completely horizontally, open it at an angle so that it's rubbing against the nucleus. When you start rotating it to get it behind, be very watchful that is there any movement of the nucleus happening. That means you've not opened enough. And that tends to be sort of a psychological thing that in the first few cases we are quite fearful, so we don't open it adequately. But again, because it's elastic, open it as wide. It does not cause any damage to the capsular excess as long as it's well done. It might stretch the capsule, but it will not damage it or tear it in any way. Then after that, the actual division part is quite easy, but it can be a little tricky at times to remove it also, because again, if you don't have the muscle memory of rotating it enough, you might capture the iris or the capsule bag as you're retracting it if you are too fast. So just retract it slowly, making sure the loop doesn't get engaged in anything.
Thank you so much.
Sir, this looks very promising. The problem with this is mostly the people who come with brown cataracts are not into that economic state of going for that high package of surgery. Also, like you talked about, in small pupil, you can use it to do the inadvertently, if we go above the rex's margin, so what all damage can it do and how can it complicate the things?
Fair enough.
Because we can't see the margin properly, right, in small pupil, especially in PXF.
So that's why when you are using in a small pupil, especially if the cataract is not too dense, you want to make sure you're already sort of going below the cortex. Then that will make sure that as it opens up, it's opening up in that plane and it'll actually go underneath the capsular margin. The second point is, let's say, okay, even if you missed it and you're opening it up towards the sulcus, you will feel a reasonable amount of resistance, which tells you that something is not okay, because when it goes in the bag itself, the amount of resistance faced is negligible. So that's quite comfortable. And again, coming back to the initial point that how is this different than stainless steel? Because it's not very rigid. Even if you're in there next to the zonules and you start bending it, it'll not damage the zonules.
So if we have halfway opened it, we can close it again and then...
Absolutely, absolutely. Okay. But the thing is, at that point, if let's say you are there, and you're struggling, don't close it over there. Then rotate it again, back up a little bit, and then gently close it.
In your experience, has it caused any damage in any case?
In my hands, no. When I have tried training others, only once has it, and that also because again, when they were struggling, they just quickly closed it. But otherwise, no. I'm using in a lot of cases, very safe device.
Thank you, sir.
What are the chances of getting zonular dialysis, because the zonules are weak with the brown cataract, with the beginners, and as it is not that much controlled, because the nucleus was getting down while you were snaring it.
No. So the nucleus is not going to go down when you are snaring it. The nucleus can come up a little bit. But at that time, it is already relatively free and you're getting 2 pieces that are coming up like that. You're not getting a whole nucleus that is coming up and bringing the bag along with it. So when that nucleus comes out, there's no risk of it damaging the zonules or the bag. The risk is that it comes and hits the endothelium.
It may flip.
That's fine. If it can't flip. It can't flip because it cuts it.
Okay.
It cuts it. So it'll cut, it'll get two pieces up, but flip can't happen.
You see, as he had mentioned in his talk,
Second instrument.
the reason why there will be no stress on the zonule is that the force of the loop is centripetal. There is no force acting on the zonule. All the force is only directed onto the nucleus and cut into two. So there is no movement which is taking place which can have effect on the zonules. That is why you can do it even if the zonules are not strong.
Thank you.
How about applying this thing in SACS, manual SACS?
Yes,
Your view.
you absolutely can. I think someone mentioned the economic parts. It would change the economics of SICS completely, but it'll be an excellent device for those very hard black cataracts.
We can cut down the size of the incision and...
Yes, it's very good for...
Yeah, initially they started with the wire loop.
Yes, yes.
So another question is, you said 4 cases we can do.
Yes.
So in between, like one case you finish in the same day you have to do all the 4 cases, or
So
you can keep it in some formalin chamber or anything?
no,
like
you
that?
can just dry it, ETO it, and use it again.
Okay, ETO.
Yeah.
Thanks.
So I also wanted to just share my experience. I don't have that much experience, but I've used it a few times. And yeah, no complications, like it was pretty easy learning curve. And yeah, this was new, that the video that you showed with the capsular tensioning, I've never tried that. So that was great. And also just that there was no second instrument that you had for some of the cases on top. You could just close it and it didn't really do any damage. That was also new, so thanks for that.
Any other question or comments from the audience or anyone who wants?
Sir, one question. Suppose if there is a posterior polar cataract along with this hard cataract, and you are not able to diagnose it pre-operatively, then there are chances of this PC rent during applying this loop?
There can be, yes.
Yes, one thing.
But so I've actually had a discussion with one surgeon where they were like, if it's a soft posterior polar cataract, maybe you can actually put this in the cortical plane and then use it. And I was like, no, I don't think that can happen. But the reality is, if it's a posterior polar, what other options do you have?
Yeah.
So with dense cataracts, by default, you proceed assuming it is posterior polar. You'll do a gentle hydro if at all. Again, as long as you don't open it too much, it's not traumatic at all. Okay. It might actually, I mean, depending how strong the edges of that posterior polar defect are, it might leave it intact also.
Okay. Usually the posterior polar cataracts are associated with a soft white mature cataract rather than a nuclear and hard cataract. So the chances of having a PPC with a hard cataract are very less.
Any other questions or anyone who thinks of starting it, any point someone want to ask, if any barrier they feel in starting the simple and economical technique? No? So we move on to the next talk then.
Sir, next AIC we can start a wet lab using that to train new surgeons.
I will talk to Zeiss about that. I will pass the idea along.
Let me thank the audience for a lively discussion that you have really made it great and asked a lot of questions about it. Most of the difficulties have already been covered. I'll be just briefly going through, is the femtolaser assisted cataract surgery still relevant for the brunescent cataract? Of course, yes. Hard cataracts, they need to be cracked. As I said, they need a strategy. They need tools. And flax is one of the tools which comes very handy when you are handling these cases. As I had said earlier, that it is the first divide and the first fragment which is the most difficult. And these are the situations where flax comes to your rescue. That is, it makes sure that you are able to divide the nucleus into two halves. And even if it is a leathery, except for the posterior 500 micron, which is not cut with the laser, you have a divide in the cataract. Even if it is a very hard cataract, still flax will be able to cut The only change that we will do in the settings is the number of passes. Normally, we'll have setting at 3 passes. That means the laser goes through the same point 3 times. But when we have a hard cataract, we'll make it 5 passes. That means the laser will go through the same plane 5 times, so that you have a little more separation or a clearer cut in between these. So now this is the flag starting. And if you see at this point, you already see the grayish area. You have a pointer? You already see at from 1 to 3 o'clock position, you see a whitish area coming. Now, this is very typically seen in hard cataracts. When you're doing flags and you see this kind of appearance, that means that this is a hard cataract, and you should be ready to change your plan or something for, yeah, this is the one. And if you see it, notice there are two. This is one and this is the second. Now, this is because because of the hardness, the only plane in which the gas bubbles can go is in between the laminae. So it will go both anteriorly, posteriorly, and give you a separation kind of a between the fibers also. So this takes care of your dividing the nucleus into, normally I'll do 6 fragments. I'll not go in for softening of the fragments, because if you do the softening of the fragments, then it's very difficult to hold this. So I'll make typically 4, 5 passes, 6 segments, and no softening to be done. This is another case flax being done. And again, you see that similar kind of a pattern appearing. This means that I have a hard cataract at hand. There was a mention about the posterior polar cataract and the dehiscence, if you have a pre-existing dehiscence. Now, these are the cases where flax becomes very handy. Once you do the scanning, you will be able to see the dehiscence in the posterior capsule, and you will change your plan accordingly. Now, this is going ahead with the surgery. Already we have seen very nice videos, but as was mentioned from the audience that debulking should be done, I would do debulking. This is important because already it's a hard nucleus, big nucleus. Bag is not much of a space in the bag to handle. So therefore, if you can debulk, it will be easier for you to separate the fragments and achieve a complete division between the fragment. And I'll try to go as deep as possible. One of the signs here which says that you should not go beyond this is if an air bubble comes. That means you are close to 500 microns, and that means you have separated most of it. Now, this is what is going to be again most important step. This is the first divide. And at this stage, make sure that you divide into 2 complete fragments like the my loop does. Don't leave it at something which is short from the center of the nucleus. Make sure that it goes beyond the nucleus. If you can divide into 2 halves, very good. Otherwise, at least you should achieve 80%, 70, 80% of the complete separation and see a good reflex which will make your job. Now, this is where I. So then you rotate it. And after that, your emphasis should be on the first fragment, because once you have removed the first fragment, then there is both lot of space, and then also when you are chopping, you have enough space to separate it completely, so that you have enough space to work and separate it completely. And try to remove the fragment completely. You don't leave the small pieces also. and you change the position of the tip, not to pull the fragment towards the tip, but to use the fluidic forces to whirl it around close to the tip, and use your chopper to block the movement of the fragments as they are moving in the anterior chamber. It is the hold which is more important than the force of the chopper. If you have a good hold, you will be able to remove it, and then you are able to remove the fragments, and in the end reduce the power. Now, one point that I would like to mention here is what I have experienced many times in these hard cases. These pieces are hard, and once there may be a longer fragment of the nucleus going through the lumen of your phaco tip, and it may block the tubing, especially at a point where your tubing is going into the pump, or it is going into the cassette. So I would have a person, OT assistant, who has a torch and is there to watch if the fragments are getting blocked or not. If the fragment blocks, then it becomes difficult. Like I had a problem 2 days back, and I had to change the cassette again because it couldn't open. Or in between, once you have taken 2 or 3 fragments, just put the foot switch on without phaco power, so that the good amount of fluid goes out and it washes away whatever small fragments are there in the tubing. And this is how you complete it. This is another case. I'll first remove the epinucleus, and then I would like to debulk it, primarily to make a space for the first time. Try to go as deep as possible, but definitely go beyond the cuts in the middle. That is the central core. Please don't leave a part of the central core. Remove the central core, and your trench should go beyond the center where all the lens fibers are crossing each other. And once you have made the first chop, then it is easy to, and you have to push back the left half, because some of the fibers from the right part of this are still there. Once you have removed the fragment, first fragment, then becomes very easy. Like I tried, there was a small piece left, but I removed that before moving on to the second fragment. And after the first fragment is removed, you have enough space to slide the fragment a bit, which separates it from the cortex also, makes it free, and it makes it easier to be removed. And after that, it is just your patience and perseverance. Go slowly. Most of the battle has already been won. And then you remove the rest of the fragments, and then go ahead with the implantation of the lens. I would always, as you had seen, that when I'm removing the fragment first and second, I would like to push the cortex back and just remove the nucleus. I don't want the cortex also to come along with it. I would like to leave the support of the cortical plate for some time, or till all the fragments have been completely removed. And as was mentioned earlier, the fluidics of the needed machines are really good. This is our center. And with that, I thank you all, and we open to question and answers now. Any questions, comments, any personal experiences, anything anyone would like to? So we had a good video presentations by Dr. Jagatram on how to crack the hardest ones, and very good discussion following that. And we had on a MyLoop presentation, which appears very convincing that there's no reason why one should not go into that. And if you have access to Flax, it makes your life much easier. It makes your results more predictable. It reduces the risk of complications. And it gives you a clearer cornea in the immediate post-op period. So if there are no questions, shall we come to the end of this course? And thank you so much, everyone, for being with us on the first afternoon of the day. Thank you so much.